Hi, I'm Dr. Mila Brujic, and I'm joined with Dr. John Gellies, where we're going to be talking about catching the early keratoconic cornea on the OI show. John, welcome. Thank you for being here. You are one that has really hit the optometric main stage very, very quickly. And I still remember the first time I saw you lecture, truly impressed especially with the amount of time that you've been graduated and the experience that you have and the things that you're working on too. So share with the audience a little bit more about your practice and kind of what you're involved in before we start kind of jumping into the substance of the discussion today.
Awesome. Thank you, Mila. I really appreciate, giving me the opportunity to be here. Yeah, our practice here, we're a tertiary cornea center. We're in Teaneck, New Jersey at the Cornea and Laser Eye Institute, the CLEI Center for Keratoconus. And, we just do all things cornea from, refractive surgery, corneal disease, really heavy subspecialty interest in keratoconus, and, obviously with me, specialty contact lens. So
yeah, that's great, John. And from what I understand too, you're with three ophthalmologists, and you're really their cornea specialty lens guy, correct? I mean, you're really kind of working with these more advanced anterior seg disease patients and making sure that they can function and see.
Yeah, that's correct. The vast majority of what I'm doing is, irregular corneas and severe ocular surface disease. I've been blessed to work with Peter Hirsch and Stephen Greenstein and David Chu, two, really top-notch cornea refractive guys known for work in development of refractive surgery and treatment of keratoconus. And then David Chu, who's a cornea and ocular immunology specialist, who's just out of this world. So we get all the train wrecks from all sides, and it's just a blast working here, got to tell you.
And John, it's great that you've kind of really taken on this challenge, because it's people like yourself that are working with these individuals that are improving their life. With that said, John, I mean, you're so far ahead in terms of the technology curve. I wanted to pick your brain on two big topics when it comes to cornea. And the first is, I want to dive right into it, keratoconus, but I want to go into something very, very specific. See, I graduated in 2002, and when we graduated, it was kind of a fairly well-known number that keratoconus happens in about 1 in 2,000 patients. And what we know is that's totally changed. Those numbers are totally different, because the way that we diagnose these individuals has completely changed. I guess, really, what's that number look like today? And how can we in primary care settings really get better at identifying these individuals in order to get them the treatment they need sooner?
Yeah, no, I think it's such an important point on it. Keratoconus being kind of a passion for us, and having the subspecialty center and doing the research in the area. When you look at that number, 1 in 2,000, that's really derived from, Olmsted County data from, I want to say it was 1935 up to like 1982. And, it's done with using classical instrumentation, this sort of stuff you'd have in your lane. Whereas now those numbers are more like, if you look at like Hashimi's paper that was published late last year, it was a meta-analysis on prevalence and incidence, and we were seeing numbers that were somewhere around 1 in 700 based on the newer data. And then if you go to the smaller cohorts, there's registry data out of the Netherlands that says 1 in 375. You got studies coming from New Zealand and and Australia that are showing numbers like 1 in 191 or 1 in actually 82. So you have these numbers that are showing you that it's just extremely, just way more common.
Yeah.
And the big difference between it is, the ability to have these advanced levels of testing these days, where you can, catch subtle signs of it that you wouldn't have been able to catch otherwise.
So, John, what are some of those technologies that you feel like, these are the ones that are going to catch it at the earliest levels? Because again, I think with any condition, and I think part of the reason too that we in eye care we really kind of saw these low prevalence numbers was because we knew that when we saw it, we couldn't really do much. We tried to correct it with specialty lenses, but then what we would do is we would just kind of fix it with specialty lenses until they required, or if they eventually needed a penetrating keratoplasty, and that would be the treatment of choice. But now we have ways to intervene sooner. So I just personally think it's more important for us to catch these patients sooner. So what are those technologies that you see as really instrumental to catching and finding these people sooner?
Yeah, I mean, there's so many technologies, and like if we just use them in a way where we pay attention to the data that's coming out of them, many of these technologies are already in your practice, right? The big one that I'm, hugely pro on is, any sort of tomography, whether that comes from a shine plug camera or from an OCT, an anterior segment OCT. And, the ability to look at, anterior surface elevation, posterior surface elevation, and corneal, global corneal thickness is extremely important to the diagnosis of the disease. And then when you go specifically to OCT, you can look at, layer thickness of the cornea, and specifically the epithelial layer thickness, which in, keratoconus is going to create kind of a donut pattern. You're going to have this epithelial thinning over the apex and heaping around the base of it. These technologies are just, you can catch things so early. And many of us have corneal, or rather posterior segment OCTs that have an anterior segment function on them, and just using that to be able to screen these sorts of corneas where things are a little irregular. Now the disconnect though is when do you use these devices, right? Like it's one thing for me to say you have a tomographer, use it on everybody. That's just not realistic. So it kind of comes down to what are the signs that should trigger you to say, oh, I should get a corneal topography at very least on this individual, because like right now, if we look at like tomography, for instance, very few optometrists have corneal tomography available to them. So, knowing when to say, okay, well, this is suspicious is the big key on a lot of this.
So what are some of those things that we would see in our practice? So let's say, for example, somebody doesn't have advanced technologies, or even if they do have them, what are those key trigger points where you're like, this should kind of warrant some further investigation from me clinically to kind of rule this out or understand the cornea better?
Yeah. I mean, there's a lot that like in just your bread and butter exam that should trigger that sort of thought process. We could go through the classic sort of stuff, which is a K value on your auto Ks of greater than 48. Or if we're looking at, an autorefractor, getting an error on your autorefractor should tell you that there's something, irregular about that surface. Having big asymmetries between the eyes and the amount of, myopia or the amount of astigmatism that's present. Specifically, though, the one that I kind of want to talk about, we just submitted a paper on this where we did a meta-analysis, or not a meta-analysis, an analysis of about retrospective analysis on about 1,200 eyes of keratoconic patients of various different degrees. And what we looked at was their refractive data, their manifest refractions, and we looked at the autokeratometry, and we related that back to the Pinacam scans that we had, looking at the Kmax and IS ratios and all those sorts of factors. And what we found was actually very, very striking. About 80% of individuals with keratoconus in the entire cohort had oblique or against the rule astigmatism, regardless of what age they were. When we took a look at the amount of myopia, if we looked at like the Amsler-Krumek that always said, like this thing was established in 1946, it's a very outdated scale, but when you look at it, there are some classical things on it that are, that it's helping you grade with that are just basically based on a normal examination, right? You have your K values, your manifest refraction, and your slit lamp findings, right? One of those things is like progressing amounts of myopia that like basically starts at -5. When we looked at the entire group, like the entire group didn't ever get to -5, whether it was like, just the sphere value, just the cylinder value, or a spherical equivalent. So, there's a lot less myopia than you would think. Like when we were looking at the numbers, it was like 40% of these guys were hyperopic or emetropic. We saw a lot of astigmatism. So when we looked at the averages that were really important on this, it was against the rule or oblique astigmatism in either your refraction or your K values, and a corneal or refractive cylinder of -2 diopters, right? So if we had anything in that, that was actually a good indicator that we should be able to, or we should go ahead and get a corneal topographer or a topography and work that patient up for a corneal malady. It's very interesting.
It is interesting, John, because the things that you bring up are, and we're all learning. We're in the learning phase right now. So as you're kind of collecting this data and we kind of communicate and talk about it, it's so true even with what we're seeing now with our more advanced technologies. Because again, these patients with traditional technologies would have been missed until they got to phases that were so severe that you're now questioning and saying, well, we now have to do something. And it almost seems like, and please correct me if I'm wrong, but we as a profession have kind of dropped our diagnostic barrier to a point where we're now starting to become suspicious earlier, because we realize you don't have to have the high myopia with keratoconus. You can be hyperopic and have keratoconus. You can be emetropic with cylinder and have keratoconus. So again, all of these kind of classic rules that we were always fed with the traditional technologies have totally changed over the last decade. And it's cool that I'm talking to one of the guys that are actually making those changes happen. John, I have to touch base with you on this as well, too. So there's another big change that's really kind of coming now within eye care, and that is more personalized medicine and genetics. And there's actually tests now that give us the ability to determine or detect somebody's level of risk of having the genetic predisposition towards keratoconus. Give me your thoughts, give me your opinions. Where does this really play a role in our practices and for the longevity of the patient's well-being, essentially?
Yeah. Well, I got to credit you on this, because I think you said it the best that I've ever heard, which is that, there is an environmental factor in an individual's life that is going to help impact the disease that they have, right? And then you have the genetic factor. Now, previously, we didn't know about the genetics, right? We could say that your family history was X, so we think that you're going to have a higher risk, but we couldn't know that from an objective standpoint, right? Well, now that we have the ability to do these genetic tests, we're going to be in a position where we can say objectively, you have these markers, which are part of the association for keratoconus in this case. And we can now use a polygenic risk score where we're taking all those factors from all those genes and creating a risk scale and saying, look, based on the genetics, you have the propensity for a high risk of development of keratoconus. So for patients who, let's say, I have a ton of patients every day, and you do too, that come in that have keratoconus and ask, I have a son or daughter, and they are 8 years old. I want to know if they have keratoconus or if they are going to develop keratoconus. And if we were to screen that individual at that time, and we had a very regular cornea, and we were to get a genetic test at that point, our management of that patient may change, right? So if I saw somebody with a normal cornea prior to having that test, many individuals would have said, you know what, maybe I'll see you back in 6 to 12 months. Everything looks nice and normal. But if that individual had that normal corneal shape, but let's say their genetic testing came back with a high risk for development of keratoconus, in my mind, what would happen then is I would treat that like a high risk of progression in glaucoma. I'd say, oh, this individual has high risk factors. I'm going to follow up with them in 3 months instead of 6 to 12 and see this individual so that I can monitor for those changes. And the second they have any sort of change, I basically lower my threshold on what I would classify as a progressive movement in this individual. And maybe we might get to the point where, it's recognized that high risk is just a reason to go and have this. But what we would do is, we'd refer them for corneal collagen cross-linking at that point. But it really affects your management, right? So let's take that individual and let's say that they have no genetic risk marker, right? I would feel a little bit more confident in saying, look, we're still going to watch this on about a 3 to 6 month level. But you don't need to have that immediate worry for this, right? You can relax a little bit. It may happen, but in the other event where it's a high risk, we may find that individual and say, look, we should have a more serious conversation and have a plan together about how we're going to move forward on this. And if this happens, this is how we are going to react to it.
John, in my 4th year of optometry school, so 20 years ago, I wrote a paper on keratoconus risk, understanding the condition, trying to understand why it occurs in some of these individuals. So I could always describe exactly why it happens, but we didn't have the technologies yet to identify it early or identify those risk factors early enough. And I never thought we would. In my clinical lifetime, I never thought we would be talking about keratoconus the way we are right now in terms of early levels of detection. And what you've kind of exposed the audience to is just a new way to think about this condition, because we have now, fortunately, good ways to treat it with corneal cross-linking and ways to prevent progression. That's, again, one of the most encouraging things about this condition is we can now do something about it. And when we have a solution for it, isn't it so rewarding when you catch these patients early and are able to provide that for them? So I, John, I could sit here and talk for hours with you about this. I mean, this is obviously a passion of yours, certainly a passion of mine. We do have some time constraints. John, I do appreciate you being on the show here. Really, really appreciate your time. Appreciate everybody being here with us, and make sure that you subscribe to our channel and make sure you listen to other podcasts as well too. John, thank you so much.
Thank you. This is a pleasure.